So,
Yeah, great. So, good evening, all of you, and let me welcome you to the today's edition of the Fine Evening Clinics, and particularly welcome Dr. Madhu Nagappa. She is the expert today. She, as you know, is a professor of neurology at the prestigious NIMHANS, and her
additional
area of
professor.
yeah, oh no,
Additional
professor,
professor.
additional as professor. And her interest is in nerve diseases, and she has a lot of publications on peripheral nerve, and she's one of the well-known experts in the field. So thank you for coming today to this class, Madhu. And as usual, I think we have four people in the panel and one presenter. The presenter is Sumit, and in the panel we have Abhay, we have Riddhi, Ameya, and Praveen. Did I get the names right? Ameya and fourth Praveen is correct.
Yes,
Fourth
sir.
is Praveen. Yeah. So Praveen and Ameya are from NIMHANS. They're finishing the DM. Riddhi is from Bombay Hospital, and Abhay is from the Grant Medical College. So let me welcome all of you, and without further ado, let's start the case. So over to you, Dr. Madhu. And Sumit, you can share your slides and start. Sumit, Sumit, you sharing your slides?
Yes, sir.
Yeah,
Yes.
good.
Are the slides visible, sir?
Yeah,
Yes.
yeah,
Sir, I will start.
great, great. So I'm going on mute.
So, patient is a 37-year-old male, resident of Palghar, construction laborer by occupation, right-handed, came with chief complaints of paresthesia and weakness of left lower limb from last 3 years, paresthesia in right lower limb from last 2 years, imbalance while walking with change in the gait from last 2 years, and paresthesia and weakness in the right followed by left upper limb from last 1 year. Patient was apparently all right till 3 years back when he started complaining of paresthesias as tingling sensation involving left lower limb. He also found that there is slippage of chappals from his left lower limb unknowingly for last 2.5 years. Then he started complaining of difficulty in wearing chappals in left foot and needed help of his hands to wear chappal. He also complains of numbness in the left foot with impaired pain and temperature on further inquiry. After 1 year, he started complaining of frequent tripping while walking. He needed to lift his left leg more. His wife noticed high steppage gait. He later started complaining of paresthesias in right lower limb with no difficulty in wearing chappals or slippage of chappals while walking. For last 2 years, he complains of imbalance while walking, which would worsen in the dark. He also complains of imbalance while washing his face. It progressed further so that he needed mild support while getting up, and for last 1 year, he needs support while walking to avoid fall. He also needs to look at his feet while walking. For 1 year, he also complains of paresthesias in both upper limb, which is more in the right than left. It is followed by weakness and thinning of right more than left hand. It was followed by difficulty in fine activities like buttoning and unbuttoning. There is no history of difficulty in gripping and overhead activities. No complaints of sensory loss also, and there is no fasciculations, tremors, or involuntary movement. He does not have any history of vision loss or loss of smell. There is no history of diplopia, dysphagia, or dysarthria. There is no history of sensory loss or paresthesia over face. There is no history of deviation of angle of mouth. There is no history of hearing loss, loss of taste sensation. There is no history of neck pain or radiating pain in the extremities. There are no complaints of bowel, bladder, sleep, appetite. There is history of exposure. He used to work with some diesel engine at his work. There is no history of joint pain or rash or weight loss. There is no history of skin lesion or rash. There is no history of exposure to any medications or toxins. There is no history of blood transfusion or hepatitis. There is no history of hypertension or diabetes or chronic liver disease or kidney disease. He has a mixed diet. He has been alcoholic for more than 15 years. He used to drink 180 ml daily for more than 15 years, and he has stopped for last 3 years. And he was a tobacco chewer, and there are no history of any high risk sexual behavior. So summary: patient is a 37-year-old male with a 3-year history of insidious onset and gradually progressive uh, asymmetric onset sensory motor involvement of bilateral lower limb followed by bilateral upper limb and sensory ataxia.
So at this point, as we understand, the patient has got 3 sets of complaints. One is sensory, other is motor, and the other is imbalance, right?
Yes.
So would anybody like to discuss or localize this first, that is the paresthesias of the limbs, which is of asymmetric onset, first involving the lower limbs and then the upper limbs. So Dr. Riddhi, Dr. Abhay, Dr. Amaya, or Dr. Praveen, anybody would like to discuss this first symptom of paresthesias?
Yes, madam.
Would you like to have any clarifications?
Yeah, I would like to know how was the onset of the paresthesias, whether what is the distribution?
The paresthesia
Part
first
of the-
occur in the left lower limb, and it was asymmetric, and the whole left lower limb was involved, and then it progressed to right lower limb and then to the upper limbs over next 1.5 year. It's,
How does that help you, this distribution of paresthesias? Why do you want to know that?
it is asymmetric onset, so it is not symmetric, so it rules out other causes like nutritional and
No, first we'll talk about the part of the nervous system that is involved. After that, we'll go to the etiology.
Ma'am, actually, the paresthesias they are because of the large fiber involvement, and there is also motor weakness is also there. So sensory plus motor
There are
involvement.
2 or 3 types of or domains of localization that will be required. One is that whether is it coming from the central or the peripheral nervous system. If it is from the peripheral nervous system, which part of the peripheral nervous system it is coming from? Is it coming from the root, the plexus, or the nerves? And then within them, we have to localize whether they are involving the large fiber or the small fiber, whether they're involving the sensory, motor, or autonomic, or all of them. If all are involved, then which is involved more? Is there any preferential involvement of one or the other? So let us first begin with the distribution, like Dr. Amaya has said. So based on the distribution, can we tell which portion of the peripheral nervous system is affected? Anybody would like to discuss, Dr. Abhay or Dr. Riddhi or Amaya or Praveen, based on the pattern of distribution, how it would help us?
Ma'am, it started distally and progressed to involve the proximal involvement was there. So
Are
maybe.
we not able to hear you clearly?
Hello, am I audible, ma'am?
Yeah, Riddhi, that's better now. Yeah.
So paresthesia started distally and that progressed to involve the proximal involvement was there. So it's looking like large fiber peripheral neuropathy type. But the nerve involvement is more likely than the root or plexus involvement because associated radicular pain is absent and the symptoms are like bilateral, but that is asymmetrical. So plexus usually used to involve the one limb, but could be the both side. And
Was the patient able to tell Dr. Sumit at the onset whether it involved the lateral side of the limb or the medial side, or
patient could not localize to whether it was in a particular one side of the limb. It was he said only left lower limb, and he could not localize to particular part of limb. So based on this onset, paresthesia can be localized to nerve or nerve root in this case.
So you mean to tell that nerve as in polyneuropathy or multiple nerves getting sequentially involved as in mononeuritis multiplex?
As it has progressed to involve another lower limb and then to upper limb. So mononeuritis multiplex is a possibility here, but other possibilities are asymmetric involvement of large fiber nerve also is a possibility, and asymmetric involvement of the nerve root is also a possibility.
If they are nerve roots, which nerve roots are involved?
Nerve roots will show a particular distribution of paresthesias.
Based on that, the available information, which nerve roots are involved?
Lumbosacral involvement in the lower limb, then in the upper limb cervical nerve root involvement.
So lumbosacral means we have L1, L2, L3. You mean to say that they are
likely
all
from
involved?
L5.
Pardon me?
L5S1, ma'am, in the lower limb, and around
L5S1 root.
C81 in the upper limb.
C81. Can anybody tell what is? Okay. I have a question. Were these paresthesias continuous or they were intermittent paresthesias? Was there any aggravating or relieving factors? You didn't mention them in your history.
I'm sorry, ma'am, but he did not complain of any intermittent paresthesia. He said that they were continuous and there were no aggravating and relieving factors.
No aggravating or relieving factors.
Yes, ma'am.
Any pressure on the foot or any pressure over the joints that increases the paresthesias, but because sometimes they are more sensitive, these nerves, to pressure. Was there any increasing or precipitating factor like that?
No, ma'am, I could not find any history about that.
How severe were these paresthesias? Were they disturbing the patient's sleep? Because they may have implications not for localization, but eventually we have to treat the patient. So how severe were these paresthesias?
He said that he could sleep, but he has to wake up, and despite the paresthesia, he could work.
Okay.
His usual duties.
Okay. So I think in the whenever we get sensory symptoms, we look for both positive and negative sensory symptoms. So this patient has symptom onset with positive sensory symptoms. It's always good to add the distribution of paresthesias. Specifically, go into the details of the distribution of paresthesias. If the patient has come with a chronic history, then one has to make some efforts to find out at the onset where the paresthesias began and how they spread, both in intensity as well as in the distribution, because that may give some idea regarding the site of the peripheral nervous system that is affected. Eventually, if everything becomes symmetric, then we may mistake it for a polyneuropathy. If it's a mononeuritis multiplex becoming confluent polyneuropathy, then the list of differential diagnosis is quite short as compared to polyneuropathy, where the list of differential diagnosis runs into pages. So mononeuritis multiplex has got a rather limited number of differential diagnoses. So it is good to make an attempt to
Madam, you are not audible.
By the time she comes back, let's welcome some of the senior neurologists who are in the audience. Dr. Subhash Kaul, Dr. Ashok Shirsat, Dr. Jayant Pandey. Please do contribute as and when you think. Welcome.
What happened? Yeah.
There are two. On Dr. Madhu's name. There are two boxes. Is that producing a problem, Mansi?
No, sir, I don't think that should be a problem. Probably her internet connectivity must be
Yeah.
an issue, I guess.
Okay. Yeah. Closing the other box won't help in any way, no?
No, sir.
Okay.
Now are you able to hear me?
Yes. Yes. Yes, we can. Yeah.
So then, Dr. Sumit, you have mentioned that the patient has impairment in pain and temperature.
Yes, ma'am.
Was that a prominent symptom?
It was not. It started later, ma'am. Initially, when the paresthesia started, he did not complain of pain and temperature. And when he had some difficulty in lifting his foot, at that time he noticed that there was numbness in his foot. And on further asking, he said that there was impairment in pain and temperature.
So that was about the distribution of impairment in pain and temperature.
He said that it is mainly on the foot dorsum, on the dorsum of the foot, and it has been there since then.
So that is in the dorsum of the foot. So that is not circumferential or anything.
It can point out to a peripheral nerve lesion.
Which peripheral nerve?
Like common peroneal nerve involvement.
Okay. Now this, was there any history of painless burns, non-healing ulcers, which would give an indirect clue as to a greater involvement of the temperature sense?
He did not give any. I asked specifically, but there were no history of burns or.
So that it is good to make a specific mention of that also, that whether the patient had non-healing ulcers, painless burns, trophic ulcers, so that gives an indirect indication regarding the loss of pain and temperature.
Yes.
Okay, then we'll go to the next symptom, that is his patient has slippage of footwear without his knowledge, right? So who would like to analyze that symptom?
Ma'am, slippage of footwear without his knowledge points to the more of a sensory impairment of that limbs.
Of that limbs. Then in the next breath, you have mentioned that the patient has difficulty in wearing footwear. So how would that help us? What would that indicate?
It can indicate both problems, like his motor weakness also and sensory weakness also. And
that would indicate, so that is an indicator that the patient has motor weakness as well. If the patient has difficulty in wearing the footwear, then it will indicate that there is motor weakness, and of course subsequently you have told that the patient developed a frank foot. Right. So the patient has now you said paresthesias and sensory impairment, that is pointing towards a mononeuritis multiplex, and then there is evidence of motor weakness as difficulty in wearing slippers, difficulty in retaining the slippers, as well as a foot drop gait, a high steppage gait that you have mentioned. Coming to the next symptom, you said that the patient has imbalance while walking. How would you approach a patient with imbalance?
And the imbalance was not there initially. It started later, after 1 year, and the imbalance was more on the dark or while washing his face, which points to the sensory components, and it progressed further.
Significant worsening? Was it just a mild worsening or significant worsening?
Initially it was less, but gradually it increased and there was severe worsening, so that he needed support while walking when he presented to us 8 months
No,
back.
no. What I mean to ask is when the visuals are removed, as walking in the dark or closing the eyes while washing the face, is there a significant worsening of the paralysis?
Yes, ma'am. There is significant worsening uh, on the removal of visual cues.
There's significant worsening.
Yes, ma'am.
We should remember that significant worsening is the one that tends towards sensory ataxia. Otherwise, any patient with ataxia which is quite severe may worsen to some extent on closing the eyes. So we have to gather the history of significant worsening if it is present. Then only that gives a strong indicator of impaired kinesthetic sense.
Is there any history of falls, for example?
He said that there were no significant falls. He would take care of him and would not go alone. Would take someone with him always. But there were no falls. But he thought that he would fall while walking. But there were no falls.
Is there any other indicator of kinesthetic impairment pointing towards sensory ataxia rather than cerebellar ataxia?
He says that while walking, he needs to look at his feet. So need for visual cues while walking, and
Was there any history of dysarthria?
there was no history of dysarthria.
So that if it is present, then that would favor a cerebellar ataxia. If it is not present, then that you could take it as a clue. Was there any history of visual disturbance?
There was no history of visual disturbance.
Visual, any oscillopsia, because nystagmus may sometimes give rise to a sensation of impression or blurred vision or oscillopsia.
There was no history of suggestive of oscillopsia also.
So these two, if they are present, then they would help to localize to cerebellar ataxia. If it is not there, then you may have only localization to the kinesthetic sense. There's nothing that prevents the patient have two sites of involvement. Now, have you asked a question that when he puts his hand in the pocket, is he able to identify the items in the pocket? Is he able to identify coins or the objects that are present in the? That would also help.
Specific question was not asked.
That is one good question to ask a patient, because you said that there's history of upper limb involvement. So that is one symptom that can be asked for, that when putting the hand in the pocket, if the patient is able to identify the objects that are present there. So that's good. Now, next you told that the patient has difficulty in rising from the floor, right? The patient has high steppage gait, tripping, and then the patient has difficulty in balance and difficulty rising from the floor. Yeah. So what would that indicate?
It started as imbalance, which would worsen in the dark, and with only mild support he would get up, and only with mild support he would walk. So it is unlikely that it is due to motor weakness, and his imbalance was so severe that he needed support while walking and while getting up from the sitting position.
So you're attributing everything to the sensation of imbalance.
Yes.
But before that, you mentioned that the patient has a high steppage gait. Would that play a role in difficulty in rising from the floor?
Yes, ma'am. That can also contribute.
You should remember that the patient with ankle weakness may also have difficulty in rising from the floor, because to rise from the floor, we have to root the foot firmly on the ground. The ankle has to root the foot or plant the foot firmly on the ground. So there is significant ankle weakness, dorsiflexor and plantar flexor weakness as in a flail foot. Then also the patient may complain of difficulty in rising from the floor. So in this patient, probably both are contributing to the difficulty in rising from the floor. And as you have mentioned, there probably is no proximal weakness. Was the patient able to flex the hip in supine position or in sitting position historically? Move the...
Yes, sir. He could flex his foot from in the supine or...
so that generally difficulty in rising from the floor is equated with the pelvic girdle weakness. So in the supine position or in the sitting position, if he is able to move them well, then and plus he has other features like high steppage gait and imbalance. So probably these are the two factors that are contributing to his difficulty in rising from the floor. So that is a good history that you have obtained from the patient. Can you move to the next slide? Okay. You have any other questions, or do the panel members want to ask anything else or discuss anything else at this point? There was no history of wasting historically, thinning of limbs historically.
Dr. Madhu,
Yes.
there is a question by one of the attendees. What is why we should ask about the, you asked about the pocket, the hand in the pocket, what is the importance of that?
That is kind of similar to the wash basin phenomenon. That is, without the visual cues, whether the patient is able to identify the objects that are present. It will give an indirect clue for the involvement of kinesthetic, for the presence of kinesthetic impairment in the upper limbs.
Absolutely. Yeah.
Of course, while seeing also, if the patient is not able to identify, then it indicates an impaired touch sensation. So that has to be preserved to some extent. Then only we can comment on the kinesthetic impairment with the visual of with the removal of the visual cues.
Then, madam, there is one more question that tripping and slipping of chappals is linked to spasticity.
Yeah, we talk about twisting at the ankle. I am not very sure on the tripping part. I would invite Professor Khadilkar to give his input on this.
Sir?
Peripheral nerve, generally we talk about twisting at the ankle.
I was just a little bit out, Rakesh. What's the question?
Sir, this tripping and falls, the slipping of chappals, is linked to spasticity, or it can, of course,
whether it can be lower or upper.
Yeah,
I think it can be both.
Both, yes, sir.
Because it largely depends on the way the person puts it across to us. I think it can be either. But generally, I think they would use the word dragging for upper motor neuron, and they trip for low. But they are so variable that I think it's both. Yeah.
So, do the panel members want to ask anything else or discuss anything else?
Was there any history suggestive of autonomic involvement in this patient?
There were no history suggestive.
For what are the autonomic features you're looking for?
Several autonomic features can be present. For example, we can start with visual abnormalities, like we can have a glare, or there can be cardiovascular involvement like postural tachycardia, orthostatic hypotension can be there, or gastrointestinal involvement in the form of constipation or episodic diarrhea, or vasomotor abnormalities and sweating abnormalities like anhidrosis or hyperhidrosis in one particular location.
So you're asking for diffuse dysautonomia or focal dysautonomia, that you have to specify. In the context of this patient, you want to know about diffuse dysautonomia or focal dysautonomia?
Because it is a case of mononeuritis multiplex, I would like to ask about a focal dysautonomia.
So what are the focal dysautonomia features that you would look for? Loss of sweating, loss of hair, trophic changes, loss of sweating. Were there any of these features in your patient, Dr. Sumi?
The loss of hair were seen in the hand, but under the forearm. But there were no other trophic changes, or there were no anhidrosis or loss of sweating or increased sweating seen.
So it is good to make a specific mention of that also in your history. If it is not there, with the rest of the negative history, you can also highlight that the trophic changes like dry skin, sweating abnormalities, skin changes, they were not present in this patient. You said there's no history of wasting historically.
Patient gave a history of thinning of his right upper and lower limb, and also
Okay, there was history of thinning. Okay. What would that indicate? Presence of thinning?
presence of thinning usually indicates the lower motor neuron type of problem, or and can also indicate a prolonged course of the illness. So in this case, it is mostly suggestive of lower motor type of involvement, element type of involvement. So mostly in the nerve distribution.
It indicates
And
an
Occurs.
also
If
in the
it
nerve,
occurs,
sorry.
and also in the neuropathy, if it is a axonal type, then chances of wasting are more as compared to the demyelinating.
Yeah, it's a marker of axonal loss. Even in demyelinating neuropathy, if wasting occurs, it indicates that there's a secondary axonal loss. If there is no motor, only sensory loss, can slippage of the chapel occur? Yes, it can occur. Slippage
Yes,
of slipper without knowledge, as he mentioned in his history for this patient, slippage of footwear can occur. Okay, can we go to the next slide? Okay, you have implied that there is no cranial nerve involvement in this patient, right? With
yes,
your
ma'am.
negative history, you have implied that there is no cranial nerve involvement.
Yes, ma'am. There is no cranial nerve involvement and no
Go to the next
autonomic
slide.
feature.
No. Can we go to the next slide?
Should I go?
Yeah,
Next slide.
please move to the next slide. Yeah.
So this was the summary. Then
You mentioned that the patient has petrochemical exposure specifically. Was there any reason or just for completion you have mentioned that?
I have mentioned it, but there is no history. There is no history of any diesel associated neuropathy. So I have just mentioned it due to his a part of his occupation.
Was there any family history?
There was no family history, and he was born of a non-consanguineous marriage. And
He has symptoms for 3 years, so one would think that he might have received some treatment. Did he receive any treatment at any point during these 3 years?
He was staying in the rural place in the remote area. So for the first 2 years, he did not get receive any treatment. He has neglected his symptoms, and for last 1 year, he has received symptomatic treatment only. And before that, he has not received any significant treatment.
So he's not been investigated or received any treatment.
He was not investigated before presenting to us.
So you have got possible localization as the nerve, root, plexus, or ganglion, right? In the next slide. So can you narrow down or justify why you have put these four possible sites of localization?
Ma'am, nerve is due to patient has a symmetric onset of involvement, and there is paresthesia which also has started unsymmetrically. There is foot drop also, and
so which nerves are
there are.
affected?
So foot drop is suggestive of common peroneal nerve involvement. Then there is wasting of thinner muscles also in the upper limb, which is suggestive of ulnar involvement. And
muscles or which muscle is wasted in the upper limb?
Hypothenar muscle are involved, twisted. So it is suggestive of ulnar nerve involvement, and there is a history of sensory ataxia, so which can be due to involvement of sensory ganglion or posterior column also. Posterior column, though unlikely, we should consider it there due to severity of the sensory ataxia.
How would you, can you repeat your last sentence? You said that posterior column is unlikely because of severity of ataxia.
Due to the asymmetric onset and of the nerve
concept that would not favor a posterior column involvement. That is
and the accompanying symptoms.
What are the accompanying symptoms?
There is asymmetricity and progression over to involve multiple nerve territory, so which does not suggest of a spinal cord involvement. So posterior column is unlikely, but
so
sometimes
what points would have been present had the patient had, if the patient had a spinal cord involvement? What are the features that might have been present?
And there can be if the posterior column involvement was there, patient would present with the ataxia, but it would be it should not start as asymmetrically. And
any other features?
There will be there may be associated features of spasticity which can be obtained on history.
That might have been present, features of spasticity. Anything else? If they are present, they may not be present. If they are present,
if spinal cord involvement was there, then bladder involvement should have been there. It was
bladder might have been present. With respect to sensory features, anybody else would like to try? Give their input.
There can be chances of dissociated sensory loss if only the posterior column is involved and spinothalamic tract is intact.
That is one point.
Hermit sign could have been present. Involvement of posterior columns can be indicated by that.
Band-like sensation, if it is present, then that may also indicate that there is a spinal cord. What would be
funicular pain could be.
Funicular pain if it is present. What are the features that would favor a sensory ganglion involvement?
Sensory ganglion involvement, patient has severe ataxia. It can have all the sensation involved, all type
patient
of.
Is still able to walk with support. You're telling.
Yes, ma'am.
You're telling me the patient is able to still walk with support. Yeah, please continue.
It will be very severe, and there will be loss
of. Very severe. So patient usually may have difficulty in walking even with support.
Involvement of motor symptoms like difficulty in wearing the footwear and wasting of the muscles in the upper limb. Sensory ganglionopathy usually have the only sensory symptoms.
Exactly. So sensory ganglion means that there will be only sensory involvement. There cannot be any motor weakness. There's
also,
foot drop is not a feature of sensory ganglion.
Patchy proximal sensory loss and paresthesias will be there.
Yes. A non-line dependent pattern. There may be involvement of the face, scalp, oral cavity also in a bizarre distribution. Sometimes they can be mistaken for even functional disorders. So these features, if they are present, then they would favor a sensory ganglion involvement. Here, this patient has a frank foot drop, as you told. So sensory ganglion involvement may be present, but it is in addition to a peripheral nerve involvement. That is how we would put the localization in this patient. Perhaps after examination, it will be more clear whether the patient has got really a sensory ganglion involvement or everything is related to only peripheral nerve involvement, as in mononeuritis multiplex.
Yes, I would like to. Should I proceed?
Can you move to the next slide? Yeah. So these are your list of possible differential diagnoses.
Okay. Yes, ma'am. Based on the history.
So these are as part of differential diagnosis of mononeuritis multiplex, or specifically in this patient you have considered?
Considering the presentation of both mononeuritis with sensory ataxia, I have considered these differentials.
Other, how did you arrange them in this order? Why not put MATSAM first or Sjogren syndrome first?
As ma'am, in India, Hansen's is most common, so I have put Hansen's first. The patient is a male patient and he does not
Diabetes
have
is
any
more
history of
common in India.
Yes.
Diabetes is more common in India.
Uh,
Whether the patient is from so I thought it was based on the epidemiological data from that place that you have put. Recently, it was in the news for resurgence of Hansen's in that area. Some of the districts in Maharashtra had were in the news. So was it in relation to the epidemiology that you have put Hansen's first?
and both actually mononeuritis multiplex and sensory ganglionopathy is common in Hansen's. Actually, that is the, and in diabetes, sensory ganglionopathy is there.
How about sarcoidosis?
And sarcoidosis, both can be present. Again, mononeuritis multiplex is common, and ganglionopathy is rare.
Sure, I don't have that much experience of sensory ganglionopathy and sarcoidosis. Sjogren syndrome, agreed. Sensory ganglionopathy, the commonest would be paraneoplastic, followed by autoimmune and the drug and toxin. So in that way, if you look, then Sjogren syndrome would come first. But in the history, I think if you arrange the order of importance of the symptoms, then mononeuritis multiplex with both sensory and motor involvement is predominating. So from that angle, if you see, then of course you can put Hansen's and vasculitis as the first.
And also the duration is 3 years, so we have kept the chronic disease first, and he has not received still any treatment. So he is not much disabled in all the 3 years. Sjogren's will be a very rapid progress compared to the Hansen's.
Right. Okay. We'll move to the examination so that we can discuss a little more on the clinical aspects.
Patient's vitals are normal. There were no orthostatic hypotension. Pulse was regular. There were no other systemic features. There was a hypopigmented patch on the left cheek and trunk, but there was no hypoesthesia or altered pain sensation in the patch. There were no body deformities. There were thickened nerve, bilateral ulnar, left greater auricular, and bilateral common peroneal nerves were thickened.
What
So
would be
this
the
was the
differential diagnosis based on this? You should remember that history and will help you to localize, but the etiology comes usually from the systemic examination or the systemic symptoms. So here you have a skin lesion and you have some thickened nerves. So can you tell some differential diagnosis of neuropathy associated with skin involvement?
Skin involvement is Hansen's, and then other systemic diseases like SLE and Sjogren syndrome.
Sjogren syndrome, what skin involvement is present?
If cutaneous vasculitis is there associated, then it can cause skin changes. No, there will not be hypopigmented patch, but other skin changes will be there.
I mean,
syndrome may be associated with Zika symptoms that you have not mentioned in the history, though you brought out as a differential diagnosis.
Vaginous granulomatosis.
I mean,
Poem syndrome, then?
Hyperpigmentation is there. In Refsum's, hypertrichosis is there.
Fabry's disease.
Angiokeratosis.
Okay, so you have to be aware that there are a number of cutaneous markers that point towards the etiology in a patient with peripheral neuropathy. So clinical examination is important, which will give an important clue to the etiology, because this history examination will help in localization. It will help you to tell whether there's a polyneuropathy, mononeuritis multiplex, whether there's a radiculopathy or plexopathy or a combination. But it's the systemic symptoms and signs that helps to bring out the etiology. You said there is no loss of sensation in this hypopigmented patch. So would it still favor Hansen's disease?
Yes, ma'am. There is a hypopigmented patch, but no loss. If there was loss of sensation, it was hypoaesthetic, then it would favor more. But I will still consider Hansen's disease in this patient.
You should remember that a significant proportion, at least, I'm not sure of the percentage, probably of Hansen's lesions not have loss of sensation. So hypoesthesia, anesthesia may not be present still. So if there is a skin patch and epidemiologically if the diagnosis is favorable, we still have to keep Hansen's high in the list. Just because there is no loss of sensation doesn't mean that it goes against the diagnosis of Hansen's disease. And these non-anesthetic patches may in fact be multibacillary patches. So we need to keep that in mind. Okay, coming to thickened nerves. Can you give some more characteristics of the thickened nerves? Were they symmetrically thickened? What site was involved? Were they
Bilateral.
nodular or beaded?
The nerves were
consistency of
symmetrical
the nerve?
thickened only.
Please tell Dr. Samit.
Ma'am, the nerves were palpable and thickened, and in the bilateral ulnar region.
Because normally also nerves are palpable at certain anatomical sites. So thickened is pathological. So can you qualify the thickening further?
It was beaded appearance in the ulnar nerve, but I could not get a beaded appearance in the left greater ocular or the bilateral peroneal nerve. But they were significantly thickened nerves, ma'am. Other consistency was regular, apart from the ulnar nerve.
So which ulnar nerve has got a long course from the axilla till the wrist and hand. So which portion of the ulnar nerve is thickened and beaded?
I mean, this patient ulnar nerve at the elbow is thickened.
Across the elbow, below elbow, or above elbow?
Just behind the medial epicondyle.
Does that give any clues regarding the etiology? The site of thickening?
It is usually cold part there, so chance of involving the nerve in the cubital below the medial epicondyle is higher in Hansen's disease.
Generally in Hansen's disease, they are involved about a few centimeters proximal to the fibro-osseous canals, wherever there is, and that is reflected when you do the imaging studies as an MRI or the ultrasound. Entrapment neuropathies, the enlargement is at the site or just proximal to the site, whereas in Hansen's disease, it is little more proximal to the fibro-osseous canals. So you may have in Hansen's disease the ulnar nerve thickened significantly up to the mid-arm or even proximally, starting from a little proximal to the medial epicondyle. What are the other sites of nerve involvement that you look for, nerve thickening that you look for? What are the other nerves that can be thickened that are amenable to palpation, accessible for palpation?
Supratrochlear nerve, then bilateral superficial radial nerve, then greater auricular nerve.
The facial nerve also can be palpated in the face.
Yes, ma'am. Lacrimal branches and that can also be palpated, and
supraorbital.
Then supraorbital, supratrochlear branches of the facial nerve, greater auricular nerve, then superficial radial nerve, ulnar nerve.
Supraclavicular nerves.
Yes, ma'am. Supraclavicular nerves can also be palpated at the clavicle, and then in the lower limb, common peroneal nerves will be palpated at the fibular head, and
at the fibular neck.
This,
distal
yes,
to
fibular neck, distal to fibular head.
Then you can also, if the superficial peroneal nerve is thickened in front of the ankle and proximal to it, it may be palpable. Rarely the sural nerve may be, if it is thickened, that also can be palpated behind the lateral malleolus in the posterior aspect of the calf. if there is a patch, as you have mentioned, then the cutaneous nerve supplying that, you have to palpate around the margins to see if there is a cutaneous nerve that is supplying which is thickened. And if you're able to find that, then almost there is no other DD in this patient. If there is a cutaneous branch that is supplying the hypopigmented patch, which is thickened, which is palpable, which is thickened, then you have almost no other DD. So that is an important finding. So it is important not only to just mention thickened nerves, we should also mention whether the site of thickening, the consistency, whether it is nodular or non-nodular, and whether it is symmetrical and uniformly thickened throughout the length. So these features will help to differentiate at least some of the, what are the conditions which have thickened nerves?
Thickened nerve can be seen in Hansen's disease, then can be seen in amyloidosis, then diabetes, then hereditary sensory autonomic neuropathy, and then also it can be also seen in other diseases like Refsum's disease and other Refsum's disease. And it can also be thickened in CIDP also.
Charcot-Marie.
And also in CMT. Also, they are thickened in CMTs.
CMT. Usually the determinating variety. So you see in most of the conditions that you mentioned, the nerves are diffusely thickened. Whereas in Hansen's, you have asymmetric, nodular, painful, or tender nerves thickening may be present.
In MADSAMs also, there will be a nodular thickening of the nerves.
Right, so let us move to the next part of your examination.
So higher functions were intact. Cranial nerves, first, second, and were normal. Extraocular movement were normal. There were no facial sensory loss. Jaw jerk was normal. The 7, 8, 9 cranial nerve were normal. Other cranial
Was
nerve
corneal
and
reflex checked in this patient?
corneal reflex.
Corneal reflex.
Corneal sensation were present, ma'am, and reflex also.
Please continue.
On motor examination, there was significant wasting in left lower limb, more than the right lower limb, especially extensor digitorum bovis and tibialis anterior wasting was there. There was also hypothenor wasting and thinner sparing was seen in upper limb. The wasting was more in the right side than the left, right upper limb than the left, and there was bilateral finger escape sign was also present. And on further examination, pseudoarthrosis was present, and tone was reduced.
Okay. Have you measured the girth in this patient? You said that there's an asymmetry between the two, the wasting between the two lower limbs. So
Yes, ma'am.
objective.
I have measured the girth, ma'am, but there was no significant asymmetry. Only at the forearm there was only 2 centimeter difference in the girth, ma'am. But otherwise the girth was symmetrical. There was no significant difference in the girth of the on both sides.
When there's an asymmetry, it's good to mention the girth to make your point that there is an asymmetry between the two sides.
Yes,
what is the finger escape sign?
I'm on telling the patient to keep both hand extended in the forward position. The little finger will stand away from the other fingers. It's called as
little
finger. Will stand away from the. It abducts from the away other finger.
What?
There will be a gap between other finger and the little finger. So called as a little finger escapes from the other finger.
Is it the same Wartenberg sign?
Yes. Yes.
Is it the same as the Wartenberg sign?
Yes, ma'am. Yes, ma'am.
It's the same as the. Okay. Could you describe the finding? Intrinsic muscle wasting. What do you mean by intrinsic muscle wasting, and how did you make out the intrinsic muscle wasting?
There was furrowing on the palmar aspect, so suggestive of maybe intraosseous muscle wasting, and on the hypothenor side.
Okay. You can ask.
This hypothenar wasting and pairing, can you tell where it can be seen? One example.
It can be seen in Hirayama's disease, called as the split hand.
Reverse split.
Okay.
So it is a reverse split hand where the hypothenar wasting is there. It is seen in Hirayama disease. However, the split hand is seen in ALS.
What do you mean by pseudoathetosis? Can someone explain the phenomenon of pseudoathetosis?
Patient has extended his upper limb before him, and on closing the eyes, there is some abnormal movement of the fingers or at other joint like wrist joint. Uh, so simulating athetosis. So in this video, it was there was, and at the end there is some drop of the left hand fingers, suggestive of pseudoathetosis.
How much centimeter difference in the forearm at various sites is called as wasting? I'm not sure. I don't think it is given. It is mainly for follow-up that we document to see whether there is a progression in the wasting and to document the asymmetry between the sites. The difference between the two sides, how much difference is permissible, I'm not very sure. We could ask, get input from others as well. Professor Khadilkar. What is digit 20 sign? Digit 20 sign, I think also is kind of similar to the finger escape sign. But I'm not very sure about that. Both Wartenberg sign, finger escape sign, and digit 20 sign are kind of related signs. Wartenberg sign has been theoretically, Wartenberg sign has been described in ulnar nerve neuropathy, while the finger escape sign has been described in actually cervical myelopathy, though the factual description of the signs appears to be quite similar. That is, as Dr. Sumit mentioned, the inability to oppose or adduct the little finger with the fourth and the fifth digit with the rest of the fingers. Okay, so what does the phenomenon of pseudoathetosis imply? You describe the phenomenon. What does it imply?
Ma'am, it is the phenomena is suggestive of patient is unable to maintain his position in compared to the space around him. So there is impairment of position sensation, which gets aggravated on closing his eyes.
So it is quite a significant impairment in the kinesthetic sense. It implies a significant impairment in kinesthetic sense, leading to pseudoathetosis. Okay, you can proceed with your examination.
On power examination, power of the neck muscles was normal. Power at the shoulder muscle was 5/5. Across the shoulder joint was 5/5. Power across the elbow joint in flexion and extension was 5/5. At the wrist joint, it was also 5/5. In small muscle of the hand, there was the weakness of the on the right, more in the right than the left. There was Froment sign positive in the right hand. there was weakness of the right abductor digiti minimi and first dorsal interossea, right on the both right and left hand, but more on the right hand. The hand grip was weaker in the right hand than the left, and the thumb abduction was normal on the both sides.
What is the Froment? Can you explain?
When the patient is given a heavy object like a book, instead of big, holding it with his index finger and thumb, there is a flexion at the distal interphalangeal joint of his thumb, which is suggestive of action of the flexion rather than the adduction of the at the thumb.
Because the adductor pollicis is applied by the which nerve?
Ulnar nerve.
Ulnar nerve.
Ulnar nerve. So the adductor pollicis is applied by the ulnar nerve. So the adduction of the finger is impaired. So the patient compensates by using the flexor of the thumb. That is the Froment sign. Right. So you're implying that the finger flexors are also weak. You said that the hand grip is weak. So other finger flexors are also weak, the long finger flexors. Based on your initial description, the patient has involvement of the abductor digiti minimi and the interossea and the adductor pollicis. So that means that the patient has got involvement of the ulnar innervated muscles in the hand. Right.
Yes.
Now you are bringing in the finding of weakness of hand grip. So that is the long finger flexors. So are the long fingers flexors also weak? All the long finger flexors are weak or some finger flexors are weak?
There is weakness of some long finger flexors of the third and fourth, which are weak, which causes the weak grip of the hand. And
So you mean to tell that the ulnar innervated flexors were weak?
yes, ma'am.
Was there any deformity in this patient, claw hand deformity?
There was no deformity. There was no claw hand.
There was no claw hand deformity. Okay. Right.
Ma'am, you are not audible, ma'am. I could not hear. Am I audible?
Yes, Sumit.
I could not hear, ma'am.
Please continue.
Okay, ma'am. In the lower limb, the power across the hip joint was 5 by 5. Power across the knee joint flexion and extension was 5 by 5. Ankle, at the ankle, there was mild weakness of the dorsiflexion on the right side, and EHL weakness was also there. And the left side, dorsiflexion was 1 by 5 and plantar flexion was 4 by 5. And on the left side, EHL was 1 by 5 and FHL was 4 by 5.
So based on this pattern of weakness, where would you look lesion? In the lower limbs.
In the lower limb, there is a bilateral common peroneal nerve lesion, more on the left than the right.
You said that plantar flexor is also weak. Plantar flexor and the flexor hallucis longus is also weak.
Yes, ma'am. That
The patient was able to apply sufficient effort?
yes, ma'am. He could apply sufficient effort.
Because
There was
I know
mild
the
weakness.
rest of your slides. That's why I'm asking. Is the patient able to apply sufficient effort?
I mean, he could apply the effort, but it was only mild weakness on the plantar flexion.
So do you want, does that imply that there is some additional involvement? Somebody's asked a question that I was supposed to ask. What was the power of inversion and eversion at the ankle?
The eversion was weak, ma'am, and inversion was he could invert, but due to the foot drop, he could not completely comply with the instruction, ma'am.
Right, then we'll move on to continue with your examination.
On the sensory examination, pain and temperature were absent in the right ulnar and decrease in the left superficial peroneal and deep peroneal nerve, and also left sural and left lateral cutaneous nerve of calf. The
What
touch
does
is
that imply now?
that implies that, ma'am, there are additional nerve involvement like deep peroneal, sural, and left lateral cutaneous nerve on the one side only, and so this is again consistent with multiple nerve involvement. Touch is also
Only
impaired
the
in
left
the
side superficial peroneal nerve, deep peroneal nerve, and etc. are involved. Right side, there is no sensory impairment in the lower limbs.
uh, no, ma'am. I could find only in the uh, right ulnar only, ma'am. There was no impairment in the right lower limb.
So right ulnar and left lower limb multiple nerves are affected.
Yes, ma'am.
When you're presenting the sensory findings on examination, it's good to draw a diagram. Either
This was pain and temperature loss.
yeah, good. This is a good one. Here you have shown bilateral involvement.
And the vibration was impaired up to ankle. Position was impaired in bilateral ankle, finger, and bilateral wrist. Perineal sensations were normal, and Romberg sign was positive.
How did you test the Romberg sign?
Patient was asked to stand unaided with his feet closed, and then patient is asked to stand unaided with his feet closed together, and then he is asked to close his eyes and see if there is any significant worsening in the ataxia in this patient, but patient could not stand with his 2 feet close. I asked him to stand with his feet slightly wide apart, and again after closing eyes there was worsening in his
So you have
imbalance.
to provide the description.
Yes, ma'am.
So you have to provide that description how you have done the Romberg's test. At baseline, he had some amount of the stance was wide, and after closing his eyes, there was significant loss in the posture or equilibrium, as you may tell. So that description has to be given so as to convince that the patient has got a Romberg's positivity.
Okay.
Now, coming back to your diagram here, based on this, what you have drawn, can you tell what site is affected? Is it only the ulnar nerve or something beyond that?
It is only ulnar nerve, ma'am. Both side ulnar nerve, and
what is the distribution of the ulnar nerve? Which branch of the ulnar nerve is affected here?
ulnar nerve at the elbow is
Which branch is given out by the ulnar nerve?
it supplies the thinner eminence and on the both dorsal and palmar aspect. It also supplies the ring finger and the little finger on the palmar aspect, and only distal half of the ring little finger and sometimes ring finger on the dorsal aspect. And sometimes there is involvement only just the proximal part, just proximal to the wrist on the ulnar side. So in this patient, on the right side, it has gone little proximally, but it was not this much proximal on the forearm on the right side.
What is the pattern of ulnar nerve innervation over the fourth digit, the ring finger?
And on the ring finger, the complete ring finger finger is involved on the half of the ring finger is involved on the palmar aspect, and on the dorsal aspect, the ring finger was not involved.
Can you please repeat?
On the palmar aspect, the complete ring finger was involved on the medial half, and on the dorsal aspect,
Was
there
there a
was no.
splitting in the ring finger or not?
There was a splitting
There
in
was
the
a
ring finger.
splitting. So that is the point that you have to make, that there was a splitting in the ring finger.
Yes, ma'am.
What are the sensory branches of the ulnar nerve?
Ma'am, it is a palmar cutaneous branch just before the in the lift in the mid forearm. It supplies the thenar eminence, and then there is a dorsal cutaneous. I just
Don't be nervous, please tell your good.
there was a palmar cutaneous branch and a dorsal cutaneous branch. And the palmar cutaneous branch supplies the thinner hypothenar eminence on the, and the dorsal cutaneous part supplies the dorsum of the hand on the in the same area over the medial 1.5 fingers in the distal part of the medial fingers only.
And also there is a distal superficial branch distal to the guidance canal, which supplies the fingers.
So you have to know these branches because they will help to localize whether the ulnar neuropathy is proximal to the wrist or distal to the wrist. Which branch is given out proximal to the wrist and which is distal to the wrist?
Palmar cutaneous and dorsal cutaneous are given proximally, and the superficial branch is only given distal to the wrist.
Okay, please continue with the next slide.
This was the Romberg sign. Is it visible? Okay, I will go ahead. It is not visible. Reflexes were all absent. Superficial abdominal reflexes were present. Plantar were bilateral flexor.
So this is a very interesting finding. So can you tell what is the significance of the stretch reflexes in this patient?
As there is a diffuse hyporeflexia, it suggests of sensory diffuse sensory involvement, maybe in the form of large fiber sensory involvement, or maybe in the sensory ganglia distribution.
Actually, proximal weakness is not there, ma'am. So still the reflexes are absent.
There's a comment on this, the significance of this.
You are not audible, ma'am.
There is a global areflexia in this patient. Global areflexia. So can you discuss what is the it is a striking finding. It's a very important finding. So can you discuss the importance of the global areflexia in this patient?
As the patient has global areflexia, so it suggests of large fiber sensory involvement in the severe nature, or it can be due to sensory ganglionopathy.
Yeah, that is one finding because you said that the power at the elbow, wrist, etc. are normal. You found only distal impairment, that too mainly in the ulnar nerve distribution, as I understand, and in the common peroneal nerve distribution. So you're having reflex loss beyond that region, and there's no loss also in that region. So this finding of global areflexia, that what you initially localized as possibly there is involvement of sensory ganglion as well. So the presence of pseudoathetosis and this global areflexia may be one of the strong pointer towards your localization on history, that there is a sensory ganglion involvement over and above a mononeuritis multiplex.
Yes.
Okay. Please continue.
On the cerebellar examination, there were no cerebellar sign. Gait was high steppage gait and wide waist, and the patient would lift his left foot more than his right, and this was the gait. He has to look at his foot.
Did you do the knee heel testing carefully in this patient?
Yes, ma'am. For
There was no impairment at all in the knee heel testing?
in the knee heel testing, when he was asked to look carefully, there was improvement. Initially, it was impaired, but when he was asked to look at his knees and lower limb carefully, then he could do it better. But there was some impairment initially, so we did not
That is an important finding. It is very unusual that the patient has a wide-based gait, and as you mentioned in the sensory examination, impairment in the kinesthetic sense, pseudoathetosis, and the patient has absolutely no impairment in the finger nose testing or knee heel testing. That is little unusual. So in this patient, it would have been good to make a point regarding the impairment in the finger nose testing and knee heel testing, and the worsening on removing the visual cues. That is the eye closure, doing the same test with the eye closed. The patient can do the finger nose testing on himself, not the finger test that we do with the examiner. Just the finger nose testing and the knee heel testing with eyes open and with eyes closed. Then that would have made your point regarding this impaired kinesthetic sense. It would have strengthened your point on this.
Okay.
Especially since you mentioned that he has a wide-based gait.
Yes, ma'am.
Right. So please continue.
So the patient is a 37-year-old male with 3-year history of insidious onset, gradually progressive, asymmetric onset sensory and motor involvement in the form of bilateral ulnar, bilateral common peroneal, and left lateral cutaneous nerve of calf and sural, and with absent DTRs, with thicker nerves and sensory ataxia. So based on the this summary, patient is suspected to have.
Patient also had impairment in pain and temperature, isn't it?
Yes, ma'am.
Patient also had impairment, so that also has to come. That's also an important finding. That also has to be brought into the summary.
Yes, ma'am.
Please continue.
So due to multiple nerve involvement, it is localized to the nerve, mainly due to the suggestive of mononeuritis multiplex. And as there is a severe sensory ataxia, there can be a predominant large fiber involvement also, and sensory
But small
ganglionopathy.
fibers are also involved in this patient. Since patient has impaired pain and temperature, we have the involvement of small fiber as well.
Yes, ma'am. On the top, there is mononeuritis multiplex, and in addition to that, there may be a large fiber involvement or sensory ganglionopathy.
You want to tell or and?
And
because as you mentioned that there is a significant impairment in kinesthetics and pseudoathetosis, which is while the patient is walking relatively well, there is pseudoathetosis, which implies a non-length dependent involvement. So, and global areflexia, so that favors sensory ganglionopathy, in addition to mononeuritis multiplex.
Yes, ma'am.
Right. So, what is the diagnosis?
So, based on all this history and hypoaesthetic patch, thicker nerves, patient first diagnosis was considered as Hansen's disease, and other differentials were also considered, but Hansen's was
If you
kept as a
consider
first diagnosis.
Sjogren's syndrome, then you should have done a Sherman's test.
Yes, ma'am.
If you have brought in, if you wish to bring in the diagnosis of Sjogren's syndrome, then bedside you should have done a Sherman's test.
Yes, ma'am.
Okay, so how would you investigate this patient?
So first, the routine investigations will be done. Patient did not have any abnormality in the routine investigations. His hemoglobin was normal and his blood sugar was 92. His MCV was also normal. Vitamin B12 was normal. His thyroid function tests were normal and he did not have any HIV or SBS antigen positivity. His CSF studies were also done, which were normal, and CSF VDRL was also negative.
But CSF, you have not mentioned the cell count.
Ma'am, cell count was nil, ma'am. There were no cells.
You should always mention the CSF color and appearance first, followed by cell count, because the most important reason for doing the CSF study is to look for pleocytosis. Then only the next important parameter is the protein, if there is an elevation in protein, whether it's mild or severe. So always the color and appearance and the cell count has to come first, and then the protein has to come. Why did you do CSF in this patient anyway?
As the important differential were inflammatory condition and ganglionopathy was a consideration. To rule out inflammatory involvement, we did a CSF. So if race protein were there, it could suggest the inflammatory nature of the disease.
They're non-specific, but still, if there is absence of pleocytosis or very mildly increased, they're all non-specific findings. So they are for completion's sake, we can do the CSF. Fine. Then continue.
MRI scan were done with dedicated study of the nerve roots and ganglion, but it did not show any abnormality. This is the video, but whether it is visible.
You can describe the findings, Dr. Sumit.
Ma'am, there are no abnormality seen on the MRI. There was no enhancement. There was no enhancement of the ganglion. The spinal cord also did not show any abnormality. Am I audible?
Yes.
Yeah.
Uh,
Sumit, can you show us some more of the MRI? I'm not entirely sure whether it is normal. Can you show some more in the plexus? Now, what's happening to this nerve? This one.
Sorry, sir. So it is a video and it is not getting paused.
Who has seen the MRI?
Sir, in
Who's
the
reported? Because
sir,
I'm not entirely sure whether it is completely normal. Well, you need to show more before we can. Okay, fine.
Yes.
Is there anything more to see? No.
Not in MRI, sir. There was a video, but it is not working.
The ganglia are seen in any way? Can you show some sections of the ganglia?
In this video, the ganglion are seen.
Okay. I think later on maybe show the MRN to RKS.
Yes, sir.
Yeah.
NCS was suggestive of upside CMAP in the left common peroneal. There was low amplitude in the right ulnar, left ulnar, and left deep peroneal and right common peroneal nerve. There were absent SNAP in all tested nerves, and the pattern was suggestive of mononeuritis multiplex plus sensory neuropathy or sensory ganglionopathy. The snaps were all absent, and skin biopsy was suggestive of granulomatous mononeuritis with chronic dermatitis. Though the spite stain were negative and we could not detect the bacilli, considering the clinical picture and granulomatous mononeuritis finding on the skin biopsy, patient was diagnosed as a mononeuritis multiplex with sensory neuropathy due to Hansen's disease.
What was the site of skin biopsy, Dr. Sumit?
It was taken from the hypoaesthetic patch on the left cheek, right cheek.
Right cheek. The hypopigmented, you mean?
Hypopigmented patch.
So this is a very interesting patient. The patient has features of mononeuritis multiplex with significant involvement of the kinesthetic sense, pseudoathetosis, global areflexia, asymmetric motor and sensory symptoms and signs, which indicates that there is a peripheral nerve involvement at multiple sites, that is both multiple nerves as well as proximally at the level of the sensory ganglion. As Professor Kadilkar mentioned, it would be interesting to review the MRI to see if the proximal site, like the plexus, are thickened. As you have thickened nerves peripherally, whether the plexus are also thickened, because that has been described in Hansen's disease. So, what one can learn from this case, there are a lot of learning points. Of course, the diagnosis is made, it is a treatable disease. But what one has to learn is, one is the epidemiological significance. The list of diagnosis, one has to also consider the epidemiological data while arriving at a DD. The patient is from Palghar. Was there any community history of Hansen's disease, exposure to Hansen's disease in this patient?
There was no history of any relatives or neighbors having Hansen's disease.
The patient has presented predominantly with paresthesias, positive sensory symptoms. Pain and paresthesias are known in Hansen's disease, but when you look at any textbook list of painful neuropathies, then you find diabetes, metabolic, toxic causes. Hansen's hardly ever comes in the first few in the first initial list of differential diagnosis. So it is important to consider, even if the patient has got positive sensory symptoms, the diagnosis of Hansen's disease. Second, that is a significant impairment of kinesthetic sense. When you look at once again, the list of differential diagnosis for sensory ganglionopathy, you have paraneoplastic causes, autoimmune, and drug and toxic causes, and other idiopathic causes, CIDP, etc., CIDP variants, etc., coming in the picture. So this involvement of kinesthetic sense, significant impairment in kinesthetic sense, has been described in Hansen's disease. There are many papers. Professor Kadilkar has written very elegant description of this ganglion involvement, ganglionitis in leprosy. There are papers that have biopsy established ganglionitis in leprosy also. And as Professor Kadilkar has written, it correlates with increased deformities and multibacillary phenotype of leprosy. So leprosy is one of the important DDs for sensory ganglionopathy. Thickened nerves, they give a clue when they are present. One has to carefully look for the thickened nerves. Apart from thickened nerves, it's not just enough to mention thickened nerves. One has to look for the characteristics. That is, whether they are symmetrical, asymmetrical, nodular, beaded, whether they are painful, tender. Even after treatment of Hansen's disease, the nerves remain, even though the thickening may reduce, the nerves continue to remain firm, cord-like. It is important to mention whether there are any trophic changes, painless burns, painless ulcers in such patients. Presence of skin lesion is very important. It may be present, though we are taught that the skin lesions are in the cooler parts of the body. There are certain immune zones within the body where Hansen's patches are less likely. But there is literature to suggest that even those areas can also be involved. So a thorough examination of the patient has to be done to look for any cutaneous lesions. Absence of anesthesia or hypoanesthesia does not exclude Hansen's. That is one thing that we have to remember. And of course, nerve conduction, MRI, they help in confirming that the patient has got the peripheral nerve disease. Localization, they help in selecting a site for biopsy if it is required. In your patient, we have already got the diagnosis by skin biopsy. But if we had not got, then a nerve biopsy might have been indicated. Then nerve conduction studies helps in selecting a nerve for biopsy. So this is a very interesting patient with a lot of learning points. Any other panelists would like to add anything at this point?
Can I make one or two comments with your permission, Madhu?
Yes, sir.
Yeah. Basically, I think for all of us, leprosy is a bit of a neglected area because we all consider that it is a dermatological disease, but in reality, it's a neurological disease, and very few neurologists have focused on leprosy. Wherever you look in leprosy, there is a problem. Clinical features have not been fully identified. Course has not been fully identified. Endpoints of the treatment we don't know. Dose and duration of steroid we don't know. Whether second immunosuppressant should be used, we don't know. How do we look at resistance in leprosy, we don't know. So there are far more questions than answers in this disease. And that's because neurologists haven't concentrated on it. Also, I think in clinical practice, we don't really consider leprous neuropathy as one of the differential diagnoses when we look at neuropathies, mononeuritis multiplex and things like that. Even in the private setup where I work now, once in every month or month and a half, I'll pick up a full-blown case of leprosy, which has been making rounds from doctors to doctors. Now, why does that happen? Because it doesn't enter our minds. So I think this clinic, so beautifully taken by Dr. Madhu Nagappa and exploring all the different points, should sensitize all of you towards the diagnosis of leprosy. That's the main point that I wanted to make. Once it comes to your mind, you will know how to chase it and make the diagnosis. That isn't always that difficult. Of course, this is a very unusual case and there are atypical findings and, like she said, a lot of learning points. Yeah. Great case actually, and tremendous discussion. Compliments, Dr. Madhu. Fantastic case. Rakesh, it's your case? Rakesh, you are in charge of the case? Rakesh, you want to say anything? Great. Actually, there were some simple questions in the question box which have been answered, I think. So is there anything else anyone wants to bring out?
This case was for the DNB exam last year.
Yeah. Tough one.
And tough one, and there was a lot of sensory ataxic features, and everything got mixed up. Where is the lesion? Then first tell us the lesion.
So you didn't fail anyone, no, on this case.
So very interesting case. This was Dr. Vikram and Prachi was looking after the case.
Yeah. How long have you given him treatment? I mean, the end point always worries me.
He has improved significantly. The patches have gone. Sumit, kitna improvement hai?
Sir, the sensory ataxia has improved, but still actually the videos are recent. Previously, he was very much ataxic. Now we can walk a level ground without support. But the ataxia has improved, but there is not complete improvement. And other things like in lower limb, there is some improvement, especially in the right lower limb. The left lower limb foot drop has not improved, but he has completed approximately 5 months of the treatment.
Also, I would like to draw your attention to a very beautiful paper from Dr. Tali's group on what has he called it? Lessons learned, no?
Lessons learned. Right?
Lessons learned. I think it's a beautiful paper, and I think you all must look it up. Which journal? I'm a little hazy about
Journal
that.
of Clinical Neurosciences.
Journal, beautiful paper. I think it's a large experience and how things get missed, and it's a beautiful exposition of. And I also heard his lecture once on that topic. Great. Any other points you want to tell, Dr. Madhu, before we close? Any of the panelists want to ask anything?
Just one point just wanted to make, that this patient, apart from having a pain temperature loss, he also has touch impairment, which was probably a little more, I think, more in the areas where the pain temperature was lost. Would this point to the ganglionopathy? Because if you have a proper ganglionopathy, the tactile sensibility is sometimes more impaired than the small fibers. Sumit, in this patient, I think the touch was also significantly impaired.
Yes, sir. It was in the nerve distribution only, sir. In other nerve distribution which were not involved by mononeuritis, there was no impairment of touch.
Okay.
I don't know what this actually means, Rakesh. Dr. Madhu has any comment on that? It's very difficult to know.
It would depend on, again, within the ganglion, which fiber is involved, sir. By and large, sensory ganglionopathy usually affects the ones that are supplying the large diameter fiber.
Yeah, large fibers are more affected. Yeah.
But sensory ganglionopathy affecting the small nerve fibers, small diameter nerve fibers,
Is also known.
they also have been described.
Yeah.
They,
Also, yeah.
so
Yep.
both can be affected. They can be a combination of both. Though traditionally, or the sensory ganglionopathy implies large fiber involvement, there are certain diseases like Fabry's disease where the sensory ganglionopathy is there, which affects predominantly the small nerve fibers.
Rakesh, I don't even know whether this necessarily means a ganglionopathy. I think it just means a more proximal process beyond the cutaneous and the small nerves that you classically see in leprosy.
Yeah.
I mean, it's gone proximal, but I don't know how proximal, not necessarily up to the ganglion, based on this finding. Yeah. It's quite an amazing disease. And I don't know how it gets people, why it gets people. You know, last week I saw a person who's lived all his life in Singapore. And he's got this type of large fiber. So how did he catch it? Where did he catch it? We have no idea. Yeah. Great.
Yes, actually.
Ma'am, one question was there. In vasculitis, they used to tell the preferably we used to take the nerve with the muscle biopsy. So what is the muscle we used to change
So your question, Riddhi, is whether nerve muscle biopsy together adds to the yield.
Yes, yes.
Yeah. Yeah.
The nerve muscle biopsy definitely has an added advantage because the muscle has a greater cross-sectional area. For vasculitis, we are looking for inflammation around the vessels. The muscle has a greater cross-sectional area as compared to the nerve. And more vessels are included in that. So it definitely has a higher yield from that point of view.
Yes.
There is a paper by Dr. Agadi about a couple of years ago where he has compared the yield of sural nerve biopsy versus the combination of superficial peroneal nerve and peroneus muscle biopsy. And that has shown that the muscle nerve biopsy has a higher yield as compared to the sural nerve biopsy because of this reason.
He also showed a leprosy of the muscles in one of his cases, granulomatous myositis. We had a case of granulomatous myositis, which we discussed on Saturday, and we brought out his work. Yeah.
Thank you. Thank you.
Great. So, if there are no other questions, it's time to close. So, thank you very much, Dr. Madhu. It was a fantastic deliberation and very well done, Sumit. How many hours you worked on the case?
Yeah.
4 days.
But in exam, you'll get only 1 hour.
Yeah.
And you won't have RKS to ask your questions too.
That is a sad part. Yeah. But
Rakesh is always helping them.
And you faced Dr. Madhu, who really teased it apart for you, you know. Very tough questions for you, but very well, I think.
Great. So I think we close at that. Thank you very much. Thank you all for being here so late. And we meet next Thursday, Rakesh. What do we have next Thursday?
It will be planned, sir. We'll plan it.
So you'll have to tell. Yeah. Okay.
Thank you, ma'am. Thank you, sir.
Thank you very much.
Dr.
Thank
Madhu.
you all. Good night.
Thank you so much.
Thank you.
Thank you very much.
Fine, sir. Bye, sir.
Bye.